Thank you so much, Dr. Gogoyo. It is my great pleasure to introduce Dr. Greg Tajan. Dr. Tajan is an attending urologist at CHOP and an assistant professor of urology at the University of Pennsylvania. His research focuses on the epidemiology of and outcomes for children with chronic kidney disease and urolithiasis. Today, we have the pleasure of hearing Greg's pre-recorded presentation about his recently funded PKID study, which focuses on optimizing the surgical management of children with urolithiasis.
It is a pleasure and an honor to share with you what I believe is a new paradigm for collaborative research in urology. I'll be spending the next 10 minutes describing PKIDS, or the Pediatric Kidney Stone Care Improvement Network. PKIDS arose out of the belief that we could improve clinical research in surgical disease. It arose to answer the questions of, what if we could decrease the time it takes to get clinical insights? What if we could achieve significant cost savings over a traditional clinical study? What if we could have at our fingertips trustworthy, high-quality data from health systems, people, and partnerships to bring real-world people the answers they seek? Due to the dramatic increase in the incidence of kidney stone disease in childhood and adolescence, the American Urological Association and the Endourological Society developed guidelines for the surgical management of stones for pediatric patients. Of the 8 guidelines, 4 were based on expert opinion, which means that 50% of the care we deliver to children with kidney stones is based on 0 evidence. These guidelines also reflect a larger issue. And that issue is that our national pediatric and surgical research system is well-intentioned but flawed. The current clinical research system faces several problems. Number 1, it's too slow. Number 2, it's too expensive. Number 3, it doesn't answer questions that matter the most to people. This results in a high percentage of decisions that are not supported by evidence. And it's reflected that many health outcomes and disparities are not improving. And finally, children rely on hand-me-down evidence from adult studies. However, what if we could improve? What if we could improve by decreasing the time it takes to get clinical insights? What if we could improve by achieving significant cost savings? What if we could improve by producing trustworthy, high-quality data that brings patients the answers they seek? PKIDS is designed to achieve those objectives. PKIDS is a community of patients, caregivers, and clinicians, the mission of which is to improve care for and the lives of children with kidney stone disease through collaborative, patient-centered research. PKIDS accomplishes this mission by establishing an interactive environment to generate and apply knowledge that improves outcomes that are most important to patients with kidney stones. PKIDS is an example of what's called a learning health system. A learning health system, at its core, seamlessly integrates evidence generation and evidence application at the point of care within large healthcare systems. A learning health system conducts observational research in the real world to provide better information for healthcare decision-making. And importantly, a learning health system is organized around patients, families, practicing clinicians, researchers, and health system leaders who collaborate to produce and use healthcare data. And finally, a learning health system improves care for each patient by applying new knowledge generated at the point of care. PKIDS reflects these values. PKIDS is patient-driven. The first study PKIDS is conducting arose out of the lived experience of children and adolescents who underwent kidney stone surgery. Our goal is to improve that experience and to provide families with the necessary information they need to make informed, shared decisions. PKIDS embraces partnerships. Different than the typical research network, PKIDS includes patients, families, clinicians, researchers, payers, members of industry, and healthcare system leaders. These partnerships ensure that PKIDS is asking and answering questions that are most important to patients and their caregivers, and that the results can be directly applied back into patient care. These partners are involved in every stage of our research. This includes planning the study, conducting the study, and disseminating the study results. These stakeholder partners are reflected in the organizational structure of PKIDS. One of the most important stakeholder groups are the patient and family partners, or the PKID PFPs. In addition, the Clinician Council brings information from the front line to inform the questions that are asked and how they're answered. CHOP is the data coordinating center for PKIDS, and that involves researchers who are both clinical investigators, bioinformaticians, and biostatisticians who ultimately analyze the data that's generated. And finally, PKIDS also includes members of the private sector, including payers, such as Anthem Insurance Company, and members of industry who produce some of the equipment that we use for surgical care, including Luminous and Karl Storz. And finally, we also have health system leaders within the network who will be poised to help us implement the evidence that's generated from the studies that PKIDS conducts. The strength of PKIDS is its partnerships and its diversity. There are currently 22 sites in PKIDS. Each partner site brings not only its patient population, but also its unique practice patterns and experiences. The importance of this diversity is that results that are generated reflect how care is actually delivered, and just as importantly, that this knowledge can be directly applied back into clinical care and therefore improve outcomes at each of the participating sites. The initial study conducted by PKIDS is a comparative effectiveness study of ureteroscopy, shockwave lithotripsy, and PCNL. This study is supported by a $4 million grant from PCORI, which is the Patient-Centered Outcomes Research Institute. The objective of this comparative effectiveness study is to improve outcomes of kidney stone surgery that are most important to patients. To this end, Aim 1 is to compare stone clearance for ureteroscopy, shockwave lithotripsy, and percutaneous nephrolithotomy. We'll examine heterogeneity of treatment effect by stone size, location, and specific techniques for each procedure that produce the best outcome. Stone clearance will be assessed by a standardized ultrasound performed at 6 weeks after surgery. Stone clearance will be defined by the absence of any stone greater than 4 millimeters, which was chosen because ultrasound is known to overestimate stone size by 1 to 2 millimeters, and 2 millimeters is frequently used for a size cutoff of a clinically insignificant fragment on CT for adult stone studies. Aim 2 is to compare patient experiences after ureteroscopy, shockwave lithotripsy, and PCNL. We'll be examining heterogeneity of treatment effect by age, sex, and procedure-specific techniques. These experiences will be ascertained by patient-reported outcomes, missed school and work, and unanticipated health system encounters. Importantly, the patient-reported outcomes will include a suite of promise measures that were selected by our patient and family partners. These promise measures reflect various domains of physical, social, and emotional health. The 5 domains include pain, intensity, and interference, anxiety, sleep disturbance, peer relationships, and psychological stress. In addition, we developed a unique urinary symptom questionnaire that will ascertain those symptoms that are important after urologic surgery. Within PKIDS, we've implemented procedures that decrease the burden of the study for all the patients and their caregivers, and that includes remote consent that can be implemented over telephone or video, and then also allowing participants to enroll up to and including the day of surgery. All the study-specific procedures are only questionnaires that can be administered over a mobile device or electronically on a computer at home. These questionnaires are delivered preoperatively and postoperatively at 1, 3, 6, 9 weeks, and 3 months after surgery. All the other outcomes described on the previous slides can be obtained from a systematic review of the electronic record. We include all patients undergoing URS, shockwave, and PCNL, with the exception of those for whom consent would potentially cause harm, which is essentially patients who have a febrile obstructing stone needing emergent decompression. Our goal is to enroll 1,290 patients over the next 2 years. PKIDS is a prospective cohort study, which immediately raises the question of why not a randomized controlled trial. An RCT is widely considered the gold standard of evidence in clinical research. We chose a cohort study rather than an RCT because of the unique considerations of surgery. These include, number one, a lack of clinical equipoise. Clinical equipoise, which is the assumption that there is uncertainty about whether an intervention is beneficial or better than another, is an ethical and practical basis for RCTs. However, equipoise is challenged in studies of surgical interventions, where the choice of surgery is more likely to be related to preferences and training of surgeons and where they practice. In addition, patients, as well as surgeons, are often unwilling to have their surgery determined by chance alone. Number two, procedural learning curve. Unlike drugs that are the same day they are introduced as they are years later, surgical procedures evolve over time. Much of this change is due to surgeons acquiring greater experience and proficiency. Consequently, evaluating a procedure immediately after it is introduced may detect higher complications or fail to detect differences in outcomes due to insufficient surgeon experience. To mitigate risk of complications, typically only highly experienced surgeons and centers participate in surgical RCTs. It is therefore difficult to generalize the results to real-world clinical care or understand the learning curve for a particular procedure, which has implications for patient outcomes and physician training. Number three, changing technology. Surgery is at the cusp of rapid technological innovation and adoption. It is likely that new technologies would be acquired by hospitals enrolling participants during the course of a study. Modifications of an existing piece of surgical equipment or introduction of new equipment typically would not be allowed in an RCT. This inability to adopt and examine new technology would decrease the impact of the results, which would not reflect current care. Because PKIDS generates evidence from clinical care, the results that are shown to improve outcomes are more readily applied back into clinical care. In PKIDS, we apply evidence using a rigorous approach that applies principles of implementation science, including transparency, dissemination of results, and continuous assessment of outcomes. Through this approach, we will continually refine procedures and guidelines in order to improve outcomes that matter the most for patients. PKIDS is also a platform designed to answer new and emerging questions in stone disease. Current projects that are in development or that are the focus of new grant applications include RCTs, other observational studies, investigation of rare disease, and always seeking to develop new partnerships, including with new stakeholder groups, investigators, and other research networks. As PKIDS grows, we will always be guided by our principle to generate and apply knowledge that decreases the time it takes to get clinical insights, to achieve significant cost savings, and to produce trustworthy, high-quality data that brings patients the answers they seek.
Hi again, everyone. We are fortunate enough to have Dr. Tazhin here live joining us, and we have time for one question from the audience. Greg, we have one question from our virtual audience here. I know everyone is impressed and excited about the ambitious and methodologically rigorous study you've designed, but it looks like one of our colleagues wants to know a little bit more about exactly how the results you will get will apply to the individual patient and how individual patient outcomes will be improved by your results.
Thanks, Emily. It's great to be here and a privilege. Really our goal in PKIDS is to generate results that are most applicable and most important to patients, and allow that individualized, informed decision-making process so they can consider the outcomes that are most important to them when choosing a choice of surgery. For some, it may be stone clearance. For others, it may be the amount of discomfort after surgery, the length of that discomfort. And for others, it may be the time away from work or time away from school after surgery.
Thank you so much. Again, we truly appreciate your presentation and your willingness to be here live today. I'd now like to turn the program over to Dr. Braga again, who will introduce our next speaker.
Hello. I hope you're all enjoying the SPU live. I think we had, very excellent talks. And it's my great pleasure to introduce Dr. Anthony Curry, Chief of Pediatric Urology at Children's Hospital, Orange County. He's a Walter Schmid Chair in Pediatric Urology and also Professor of Urology at the University of California, Irvine. So Dr. Curry used to be the Chief of Pediatric Urology at the Hospital for Sick Children in Toronto. He's well published in the field, as you all know, with more than 250 publications and more than 60 book chapters. Dr. Curry is a great speaker and has been around the world with his international talks and as visiting professors, over 160 lectures. So Dr. Curry, as you all know, has been the author of the prestigious Campbell's Urology chapter on vascular reflux for the past 4 editions. And one of his main research interests is on vascular reflux. So Dr. Curry, when he's not at work, he likes to improve his skills on his golf game, as well as traveling with his wife, Shahira, to visit his 2 sons. They're in Canada. So here we have Eric, assistant coach of the Raptors, NBA champion from 2019 season. And then the other son, Michael, is a pediatric cardiologist at University of Alberta. His daughter, Dina, is doing medical school in California, 3rd year. So as you can see, a very, very successful family. So it's a great pleasure, again, and an honor. I learned so much with my mentor to introduce Dr. Curry to talk about vascular reflux.
Greetings from the Children's Hospital of Orange County and the Department of Urology at the University of California in Irvine. I'd like to start by thanking Dr. Ritchie and the SPU leadership and Dr. Braga, the chair of the scientific committee, for honoring me with delivering the SPU lecture for 2020, and also congratulating Dr. Braga on an outstanding scientific program. Sadly, we could not all attend it in person, but at least we have this virtual venue to enjoy parts of that program. Today, I'd like to talk to you about the modern management of vascular reflux and how we can individualize the treatment based on risk parameters. When I was a fellow and in the early parts of my career as a pediatric urologist, managing reflux was very simple. Every child who had a febrile urinary tract infection got a VCUG, and if they had reflux, they were started on prophylaxis, and a repeat VCUG was carried out every 12 to 18 months. If they had any breakthrough infections or the reflux didn't resolve after 4 to 5 years of follow-up, or if the family was not compliant with prophylactic antibiotics, or new scars showed up on therapy, then they underwent surgical correction for reflux. To the extent that our fellows at Sick Kids in Toronto used to perform anywhere from 150 to 200 open reimplants during their fellowship. Obviously, that's all gone, and our current fellows maybe do 5 to 10 reimplants a year. With the introduction of endoscopic correction for reflux, many families looked at this and said, you know what, I don't want my children to be on prophylactic antibiotics long term, and I certainly don't want them to have those repeat VCUGs. They dreaded those VCUGs. And so they went for endoscopic correction. And it's not surprising because for a 10-minute outpatient procedure, you can convert a widely patent ureteric orifice like this into an excellent mound with resolution of reflux and, in many cases, reduction of their infections. However, there are a few important points that we must not forget. We must remember that 50% of the patients that have pyelonephritis do not have reflux. And in the first world, the majority of parenchymal changes are not due to reflux and acquired injury. They are due to developmental changes as a result of an abnormal ureteric bud and congenital dysplasia. You and I cannot change that. We also have to remember that the incidence of reflux-related renal failure has been stable over the past 50 years, regardless of how aggressive we've been with medical and surgical management of reflux. The majority of children that develop renal failure in association with reflux are the ones born with dysplastic kidneys. Grade 5 reflux and renal dysplasia or reflux nephropathy, and they run out of nephrons around puberty. We have to remember that our goal is prevention of the morbidity of these recurrent infections, the admissions to manage pyelonephritis, the emergency room visits, and the subsequent acquired renal scars. In my mind, reflux resolution or correction is not necessarily the ultimate endpoint in 2020. All the publications that we read trying to predict when reflux will resolve and in whom reflux will resolve, in my mind, are not really addressing the key issue here. The key issue is prevention of recurrent infections and the renal damage that arises from that. So if our focus is prevention of renal injury, then we should evaluate each child based on these multiple factors responsible for recurrent infections and subsequent renal injury. We are all familiar with the multitude of factors that make a child more at risk for recurrent infections. So, for example, a child that's found to have reflux after prenatal screening is a very different animal than those presenting after multiple febrile urinary tract infections. Children with higher grades of reflux are at higher risk for recurrent infections and scars, and we'll show some of these data in a minute. Children that are born with congenital changes in their parenchyma or acquired renal scars are clearly at higher risk. Children with bladder and bowel dysfunction, infants, uncircumcised males, and we know that white females are at higher risk than African Americans. If we think about it this way, then we should view reflux as a spectrum abnormality rather than a binary problem. Reflux is not black and white. And I would urge you to consider each patient based on their risk profile, so that children at higher risk deserve more aggressive intervention. The Swedish reflux trial that was published in 2011 did exactly that. They randomized 203 children into 3 arms: observation, endoscopic treatment, and prophylaxis. This was carried out across Sweden in 23 centers. The children were all under 2 years of age. The majority were girls. They all had dilating reflux, grades 3 and 4. And they all, or the majority, presented after a febrile urinary tract infection. The febrile urinary tract infection rate was analyzed by the intent to treat principle. If we look at the outcomes of this study, I think we have a couple of things to learn. Number one, there were 67 febrile recurrences in 42 girls. and a total of 8 recurrences in 7 boys. So clearly girls were at higher risk. Most of the scars in boys were congenital. They were not acquired. They did not change over the period of the study. The children that were on prophylaxis had the lowest rate of recurrent infections, 19% over the 2 years of the study period. Children that received early endoscopic correction had a 23% infection rate. And I'd like to take a moment here to clarify one thing, and that is their success rate with endoscopic treatment during that period of time in Sweden was rather low. It was only about 60%. And that's before the time when the double hit technique was widely used in Sweden. I think the results are better now. The children that were on surveillance had the highest rate of recurrent infections, 57%. That was statistically significant. So clearly antibiotic prophylaxis in a high-risk group of patients and endoscopic treatment, despite its lower success rate, reduced the infection rate in these children that were under 2 years of age with dilating reflux. In another landmark study from Sweden, 303 children under 2 years of age were also followed prospectively over a 2-year period. They all had an ultrasound, VCUG, and DMSA within 3 months of their infection, and a repeat DMSA at 1 to 2 years out. And the purpose of this study was to examine the relationship between reflux, infections, and renal damage. Now, not all those children had reflux. These are children that presented after febrile infections. The recurrent febrile UTI rate in this group was 12%, and the risk of new febrile UTIs increased with the presence and the severity of reflux. On the follow-up DMSAs, 80 of the 303 patients had an abnormal DMSA. Interestingly, the children that had no reflux or grade 1 reflux had a similar abnormal DMSAs, around 20%, and this increased very significantly as the grade of reflux increased. Demonstrating that there's a significant relationship between DMSA abnormalities and the presence and severity of reflux. This finding was also observed when we did the AUA VUR Guidelines of 2010, where the meta-analysis that we performed clearly demonstrated that the greater number of infections a child experienced, the greater number of scars were noted on their DMSA scans. So what are we learning from this? We're learning that higher grades of reflux carry increased risk for recurrent infections and new scars. In boys, most of the renal damage is congenital, and in girls, it's most often acquired and related to the severity of the inflammatory reaction with reflux as a reinforcing factor. Again, pointing us in the direction of certain factors that are responsible for putting a child at higher risk for recurrent infections and renal injury, and encouraging us to be selective in who requires aggressive medical or surgical intervention. There are certain game changers that are worth mentioning as we build our case here. The first is the question about the benefit of prophylaxis in reducing the incidence of recurrent infections and renal scars. And over the past 15-20 years, there were multiple papers that tried to address this issue, and the results were very sort of confusing. And you could argue that these were studies that were either not well designed or underpowered, or the inclusion criteria was a mixed bag of patients with and without reflux or with low grades of reflux, etc. and I can't disagree with you. However, the result of this confusion in the literature led the American Academy of Pediatrics in 2011 to put out its guidelines that indicated that because the published literature does not provide strong evidence that supports the benefit of prophylaxis in reducing infections and renal scars, there's no point in diagnosing reflux or performing a VCUG in children after their first infection, unless, of course, their ultrasounds were abnormal. And many of us in the urology camp of the equation did not agree with that statement, because all of us have seen firsthand children that presented after their first infection with significant upper tract changes, and many of the children that had a first infection go on to have a second infection. So why wait for the second infection and the potential renal injury? Because we know as the number of infections increase, so does the possibility for renal injury. Additionally, why put the child at risk for a second infection with the morbidity of that second infection if we have the ability to maybe pick up the children that are at higher risk and manage those more aggressively? So you could argue this point back and forth, but there was no evidence on which camp was correct. In an effort to resolve this issue, the NIH funded the RIVUR trial to the tune of $6 million. And the RIVUR trial was a 2-year multi-site randomized placebo-controlled trial. 607 children aged 2 to 71 months were randomized to receive either trimethoprim sulfamethoxazole or a placebo that looked and tasted the same. Children all had grades 1 to 4 reflux, and they were diagnosed after a first or second febrile or symptomatic infection. The study was carried out in 19 clinical sites across the United States. The primary outcome was the efficacy of trimethoprim and sulfamethoxazole prophylaxis in preventing recurrences. And there's a couple of things here that we need to stop and think about for a second. Number one, the majority of patients included in this study were low-grade refluxers. The majority were grades 1, 2, and 3 refluxers. And so they're more on the low-risk side of the equation. And secondly, the prophylactic agent that was chosen is an agent, trimethoprim sulfamethoxazole, as we all know, has in many communities, about 50 to 60% of the E. coli and as high as 80% in some Middle Eastern countries are resistant to trimethoprim sulfamethoxazole. So you have to wonder if a different prophylactic agent would have been a better choice for this study. The secondary outcomes were renal scarring, treatment failures, and antimicrobial resistance. The study showed convincingly that the children placed on placebo had a higher rate of infections, 25% versus 13% for the children on prophylaxis. This was statistically significant. However, you could question if this was truly clinically significant, because the number needed to treat, you needed to treat 8 patients for 1 to benefit from prophylaxis. But interestingly, as the duration of the study increased, the difference in the result widened. As far as renal scarring, the incidence of scars and the outcome scans between both groups was compared, and there was no difference overall in the overall rate of scarring, 11.9% versus 10.2% in the placebo. There was also no difference in severe renal scarring. As a matter of fact, it was a bit higher in the prophylaxis group, 4.8 versus 2.6, but that was not statistically significant. and there was no difference in new renal scars from baseline, 8.2 versus 8.4%. However, there were important effect modifiers that, again, reinforces the message that we're trying to build here. Children that had grade 3 or 4 reflux at baseline were more likely to have febrile or symptomatic recurrences compared to those with grade 1 or 2 reflux. 23% versus 14%, and that was statistically significant. Children presenting with a febrile initial infection had a higher recurrence rate than children that had symptomatic non-febrile infections. And of course, the presence of bladder and bowel dysfunction was statistically significant. There were too few boys in the study to evaluate the effect of circumcision. However, all 4 boys that had infections were uncircumcised. So, from the RIVUR trial author's standpoint, they conclude that prophylaxis reduced the risk of recurrent infections by 50%, from 25 to 13, but not of renal scarring. And they make this statement at the end of their paper in the New England Journal of Medicine. Our finding that antimicrobial prophylaxis was associated with a reduced risk of recurrence may warrant reconsideration by the AAP for the recommendations of not performing VCUGs after the first infections. Now, if you were the AAP and you're sitting here thinking about the outcomes of the RIVUR trial, you might think that it reinforces your position rather than argues against your position. Why is that? If I was the AAP, I would say prophylaxis did not reduce the important aspect of this situation, did not reduce renal scarring or chronic kidney disease. Yes, prophylaxis resulted in a modest reduction in infections, and the number needed to treat, we said, is 8, but is that really clinically significant? Additionally, the children that had recurrent infections on prophylaxis had a much higher chance of having resistant organisms than the children on placebo, that received placebo. And the question that it keeps hammering in my mind, if we had used a different prophylactic agent, let's say nitrofurantoin, would we have seen a bigger difference? Would the results have been more pronounced? And I don't think we'll ever answer that question. Another important game changer is bladder and bowel dysfunction. One of the last papers I was involved with from sick kids in Toronto was this study on the incidence of infections after cessation of antibiotics in children with reflux. So our practice back then in early 2000, starting in the early 2000s, was to stop prophylactic antibiotics once the child became toilet trained. And we looked at how many of them developed infections after, and approximately 20% over the ensuing 8 years developed urinary tract infections. When we broke them down to children who were taken off antibiotics and still had grade 1 to 2 reflux, almost none of those children had an infection during the follow-up period, whereas 30% of the children with grades 3 and 4 had infections, a significant difference between the two groups. More importantly, when we analyzed the data based on who had bladder and bowel dysfunction, a more striking difference was apparent. So children that had bladder and bowel dysfunction had the majority of the infections compared to the children without bladder and bowel dysfunction. These same observations were noted again in the AAP Guidelines, and we made some statements in the guidelines. We said that BBD is associated with more infections on prophylaxis. It's associated with less reflux resolution at 24 months. We noticed that BBD is associated with less success rates for endoscopic treatment of reflux, but not for open surgery. And we also noticed that BBD was associated with higher subsequent failures for endoscopic treatment. So if a child had successful endoscopic treatment and then subsequently had a UTI and had a follow-up VCUG, they were found to have a higher chance of recurrent reflux if they had bladder and bowel dysfunction. We also note that BBD was associated with an increased incidence of infections after correction of reflux. So it's an independent risk factor for infection regardless of whether you have reflux or you don't have reflux. And I think we're all familiar with that message now. Another game changer is the effect of the foreskin in the uncircumcised or the non-retracting foreskin in the non-circumcised boys. And we did this study as part of our prospective database for reflux at the Children's Hospital of Orange County. Between June 2014 and 2018, we had 84 boys under 1 year of age with primary reflux that were enrolled. 14 of those boys were circumcised and 70 were uncircumcised. And remember, we live in Southern California, so we have a larger population of uncircumcised males. And of course, uncircumcised males are the ones that present with infections in the first year of life. The children were followed prospectively for 2 years. And what we found was very interesting. The figure on the left shows you the grading for phimosis, and grades 0, 1, and 2 are grades where the foreskin can be retracted to expose the majority of the glands. Grades 3, 4, and 5 are the ones where the foreskin cannot be retracted and the glands, only maybe the tip of the glands can be seen in grade 3. So the glands cannot be cleansed during diaper changes or bathing. The results as far as infections are concerned were again very striking. Circumcised boys and boys with no phimosis, grades 1 and 2 phimosis, had no infections. Children with grade 3 phimosis had 14% infections, and children with grades 4 and 5 phimosis had 36% infections. So the message is, if you have a male child under 1 year of age with reflux or presenting with infections, treat them with steroids and retraction to reduce the grade of phimosis from 3, 4, and 5 down to 1, 2, or nothing. And if you can't, offer them a circumcision. If you can reduce the foreskin and expose the glands completely so that it can be cleansed during diaper changes and bathing, the risk for infection becomes equal to children that were circumcised at birth. So we've presented to you all the factors that we think are important in recurrent infections and renal injury in the reflux population. When Guy Haidas was the fellow at CHOC, he undertook a project as part of his master's in clinical epidemiology to look at how do we put together those risk factors to identify the children that are at high risk for infection and benefit from prophylaxis or reflux correction. And many of us constructed tables like that, with green being safe, red being less safe. And I remember Craig Peters showed a table like that in one of our meetings during the AAP VUR Guideline Committee meetings. And it gives a very clear picture of how we evaluate and understand this multitude of factors so that this visual can help you put your patient in one side of the camp versus the other. And the factors include sex, age, older children less at risk than infants, race, laterality, lower grades versus higher grades. Again, bladder and bowel dysfunction, one of the most important factors, and the presence of parenchymal changes, either congenital or acquired, and whether the child presented after multiple infections or in screening for prenatal hydronephrosis. And this paper was published in 2015, looking at our ability to predict the risk of breakthrough urinary tract infections in primary reflux in an attempt to define the role of prophylaxis. And in that study, we took retrospective data and then used it to construct risk categories, which we then applied prospectively to another group of patients to see whether we were accurate in our prediction on who was at higher risk for infections. At the time, our management protocol including correcting bladder and bowel dysfunction and putting everybody on prophylactic antibiotics, and if they had a breakthrough infection, their reflux was corrected. The primary outcome was the incidence of breakthrough infections during the 2 years of follow-up after diagnosis of reflux. The retrospective data that we reviewed included all the patients that had VCOGs at CHOC between 2008 and 2010 with primary reflux who had at least 2 years of follow-up. And we collected their demographic and clinical data. There were 303 children with primary reflux. 151 of them had complete follow-up for 2 years. The median age of diagnosis was 9 months, and 75% of them were females. The distribution was similar to most reflux populations. 70% of the patients fell in the grade 2 or 3 reflux. 60% were unilateral. 84% had presented after a febrile infection, and 36% had bladder and bowel dysfunction. Very typical distribution for most of the reflux population anywhere. The factors that had the highest weight on the multivariable analysis were females, high-grade reflux, children diagnosed after a febrile UTI, children presenting with bladder and bowel dysfunction, and infants. We used the retrospective data to construct our risk categories, and we applied those risk categories prospectively to evaluate their accuracy. In the prospective validation of that risk model, there were 56 patients that were included, and based on our model, we calculated that the mean probability prediction of breakthrough infections was 19.5%, and the actual rate of infection was 21%. So very reasonably accurate prediction. The model also showed good discrimination between positive versus negative breakthrough urinary tract infection cases and with an area under the curve of 0.8. So we use this model to construct the risk stratification categories. In the low-risk population, we placed children with grades 1 to 3 reflux without bladder and bowel dysfunction and the circumcised males. This was 67% of our reflux population, and their infection rates, the breakthrough infection rate, was only 8%. So clearly a low risk for an infection group. In the intermediate risk group were children with grades 1 to 3 reflux and bladder and bowel dysfunction, the uncircumcised males, and females with grade 4 and 5 reflux presenting or diagnosed after screening for prenatal hydronephrosis. And that's a quarter of the reflux population, and their infection risk was a quarter, 27%. The high-risk group were children with grade 4 and 5 reflux, females presenting after a urinary tract infection, and that was a smaller proportion of the population, 6%, and their UTI risk was 62%. And based on that, we started managing our patients prospectively, and I'll show you some of those prospective data, into a low-risk group where we did not put them on prophylactic antibiotics, and we managed them with periodic ultrasounds. An intermediate risk group that received prophylactic antibiotics and were followed with ultrasounds, and a high-risk group that we put them on antibiotics, but we also proposed early correction of their reflux once they were over a year of age. Having seen that, and I'll show you our prospective results in a second, Peter Wang, when he was the fellow at CHOC, set out to reanalyze the RIVUR trial data based on these categories. And so we went to the NIH and asked for the raw data. It took us 2 years. We had to write a proposal, and after 2 years we received all the raw data of the RIVUR trial. The 607 enrolled children were then put in a spreadsheet looking at the risk categories. Peter spent countless hours doing this. And the questions that we wanted to answer were, are there children at higher risk for recurrent UTIs in that population of 607? Can we identify those? And can we identify those that would not have benefited from prophylaxis? We used the same criteria, female, circumcision, BBD, and higher grades of reflux to construct the classification system. But because there were no grade 5 refluxers in the RIVUR trial, they were not included as part of the trial, we put the intermediate risk category patients with the high risk as one category, and we left the low risk category. And we split the two populations into the circumcised males with non-dilating reflux and no bladder and bowel dysfunction, or the females again with non-dilating reflux and no bladder and bowel dysfunction as the low risk category. So anyone with non-dilating reflux and no bladder or bowel dysfunction, basically. And the high risk category was the uncircumcised males with grades 1 to 3 reflux with or without bladder and bowel dysfunction, or the females with non-dilating reflux and BBD, or any male or female with grade 4 reflux, whether they had BBD or not. When we divided the 607 patients into those two categories, we noted that the distribution was very similar between those receiving placebo and those receiving prophylaxis. 2/3 of the patients in each arm fell in the low risk category and 1/3 in the high risk category. The remainder of the demographics were similar in both populations. Now, let's explore the results of this analysis together. When we look at the patients in the low risk category, the infection rate in those receiving placebo was 19% versus 14% in those on prophylaxis. This was not statistically significant, and it would indicate that if you take a child in the low risk category, you would need to treat 20 children for one to benefit. On the other hand, in the high risk category, 31% of the children in the placebo arm had infections versus 11% in those on prophylaxis. This was statistically significant, and the number needed to treat drops down to 5. Much more meaningful. So, in other words, 2/3 of the study population did not benefit from being on prophylaxis, whereas the high risk category patients, 1/3 of the population, demonstrated reasonable benefit from, good benefit from being on prophylactic antibiotics. The Kaplan-Meier survival analysis for infection was also very telling. And in the low-risk patients, you can see the two curves are running parallel with no widening, no one falling off here. In the high-risk group, clear benefit for prophylaxis, and the gap widens as the study progresses. Now let's go back to our patients. As I said, we've been following our patients prospectively based on these risk categories. And over the past 5 years, we've enrolled 204 patients that have had complete data, 2 years of follow-up. And you can see that the children in the low-risk category in our database are actually a smaller proportion of the overall number of patients. And I suspect that that's because we're doing less VCUGs in children after their first infection. So the patients that are being found with reflux are falling more in the high risk or intermediate risk categories. So of the 204 patients, there were 38 in the low risk category, and they were not placed on prophylaxis and were followed prospectively. They had an infection rate of 11% over the 2 years. Children in the intermediate group were placed on prophylaxis, or at least were given prescriptions for prophylaxis, and there was a 23% infection rate. Now, I can't tell you how many of them were compliant, of course. In the high-risk group, 52% of the children had an infection despite being on prophylaxis. And that's the group that we recommend early intervention for their reflux as soon as they're over a year of age. Same factors were obvious, but in this population, there was no difference in males and females, and I suspect because many of our males are uncircumcised. There was definitely a difference between the circumcised males and the uncircumcised. There were no infections in the circumcised males, and 25% incidence of infections in the uncircumcised males. That was significant. Children with bladder and bowel dysfunction had a significantly higher incidence of infections, 32% versus 14%. And children with higher grades of reflux, dilating reflux, had a 41% incidence of infection versus 16% for those with low-grade reflux. Now, as I finish my talk, I want to share a couple of key points with you. This is an interesting study that Peter Wang, when he was writing his paper, found in the International Journal of Epidemiology in 2016. And the authors here looked at the limitations of randomized clinical trials. And the premise is that if you're looking at averages in clinical trials, you may miss the differences in individual patients in those clinical trials. The picture here is from the paper, and you can see 10 faces in the perimeter and then a face in the middle. The face in the middle is the average of those 10 patients, 10 faces, excuse me. It's a compilation of those 10, or a morphing of those 10 faces into that middle face. So if our job as a physician, as a clinician, is determining the best treatment for an individual patient, this is fundamentally very different from determining the average effect of treatment in a population, which is the purpose of a trial. You look at trials and you get average outcomes. Where I would like us to go with this is when you look at big trials, whether it be the RIVUR or any other trial that you look at, it's important to look at the details of the study design and the data analysis, and interpret these data to fit your patients, to take from them what fits your patients. We, I think, clearly demonstrated that if we were to reanalyze the RIVUR trial data the way we did, that 2/3 of those patients didn't benefit much from the prophylaxis. And you could argue that the study was not designed or not powered enough to detect that difference in the low-risk patients. But how many times in pediatric urology are we going to be able to have a $6 million study and enroll 607 patients? How many more patients do we need? We need 2,000 patients enrolled. How much is that going to cost? Are we ever going to be able to achieve that? So if I can't find a difference in 603 patients or 607 patients, is that difference ever going to be clinically significant? Think about that for a moment. So my message to you is, rather than look at the outcome of a trial and say, yes, prophylaxis is beneficial, therefore everybody with reflux gets prophylaxis, think again and look at some of the papers. We've put out 3 or 4 papers on this topic on the risk categories. Look at them. It has nothing to do with reflux resolution. It has everything to do with who benefits from prophylaxis and how can we reduce infections and subsequent renal injury. So, in conclusion, are there children that are at high risk for recurrent infections? Clearly, yes. Are there children that don't benefit from prophylaxis? Yes, about 2/3 of your reflux population, in general, if you're screening a lot of patients, won't benefit from prophylaxis. So the indications for prophylaxis need to be redefined so that we are selective based on risk categories. This way we can maximize the benefit per patient and minimize the harm as far as medication and radiation. Finally, I'll leave you with a couple of take-home messages. Please remember that reflux is not a binary problem. It's not black and white. It's a spectrum. And your job as a clinician is to identify what part of that spectrum your patient falls in and individualize the investigations and treatment based on that. Prophylaxis is going to be beneficial in about 1/3 of the reflux patients. Whether they're going to be compliant with it or not, you and I cannot be chasing after every second or last patient. Managing bladder and bowel dysfunction and the foreskin is important in reducing infections. And repeat the VCUG only if you're contemplating a management change. If you've been following the patient for a while and decide that you're going to, the child is having recurrent infections despite prophylaxis, despite managing their bladder and bowel dysfunction, and you're contemplating correcting their reflux, then get a VCUG before that to determine if that reflux needs to be treated, if it's still there and it needs to be treated, and whether it needs to be treated endoscopically or laparoscopically or open. Thank you very much for your attention. I hope I was able to convey these concepts to you as far as categorizing your patients into these risk groups. I encourage you to look at some of the stuff we've put out that may help you clarify these issues a bit more, and I'm clearly open for anyone to contact me if you want to discuss this further. I think we may have some live discussion after this. Again, thank you to the SPU leadership and the scientific committee for their kind invitation, and I appreciate your attention.
Thank you so much, Dr. Khoury. This was, again, you didn't disappoint us. I'm always learning. It was a great, excellent talk. So I think we need to get started because I've been bombarded with questions, and it's a very hot topic. So I think the first one that they would like to know, if you have DMSA abnormalities, does it predict the risk of subsequent urinary tract infections?
Yeah, there's some data that indicate that if you have acquired DMSA abnormalities, or if the child has congenital, and the ones with congenital parenchymal changes are the ones obviously that have higher grades of reflux because it's a urethral bud anomaly. And these children seem to be more at risk for recurrent infections.
So another question is that I think you mentioned that, but do you think severity of vascular urethral reflux should be based solely on grade?
No, definitely not. Because, we've shown very clearly that you can have grade 5 reflux diagnosed as part of prenatal hydro screening if a child is known to have a dilated ureter and ends up with a VCUG. We've shown that these children resolve their reflux very quickly and never have an infection. So grade alone is not a determinant if grade is an important determinant if you present after an infection. But if you present after screening, grade alone is not as important.
Thank you. I think they want to know, maybe you can explain a little bit more. Used to tell us as fellows all the time, why do you think prenatal diagnosed males or boys with high-grade VUR compared to older females with recurrent UTIs are two different populations or two different animals?
Yeah. So, we don't know. So when we screen right after birth, we don't know which of that patient population is going to develop an infection after or not. So it's an interesting question. It's a very tough question to answer. But there's clearly a large subpopulation of children that have reflux diagnosed prenatally or after prenatal screening, and they do nothing. They resolve their reflux within 18 to 24 months and never have an infection. Yet there are patients that with the same grade of reflux that present after a couple of infections. And I think it's more likely that if you are a child that's prone to recurrent infections, if you have the receptors for the right bacteria that will give you pyelonephritis, chances are you will get more infections. And that we discussed all the factors that are involved with that, whether it's bladder and bowel dysfunction, your sex, your age, your grade, these are all the factors that are responsible for whether we're going to have infections and recurrence of these infections or not.
Thank you. One of the participants has mentioned that in his own experience, he has seen a few teenager girls that had been taken off antibiotic prophylaxis and developed severe pyelonephritis. So what do you think would be this current management that is stopping antibiotics? Do you think it is risky for older population, especially the females?
Yeah, that's a really important issue that has not been resolved. We don't have data on that. And so my current policy is if I stop antibiotics in a female, let's say after age 2 or 3, and she's done well until age 10, then by the time she's becoming pre-puberty, I sit down and chat with her and her family, and I say, you need to decide whether you want to get another VCUG at this point, and if there is reflux, correct it either endoscopically, laparoscopically, or whatever, versus go through puberty and be active, and then if you start having infections again, then we can go ahead and do the VCUG and correct the reflux if it's still there. You also have to remember that 50% of children that develop pyelonephritis do not have reflux. So it's not just about reflux. It's about all the other factors that result in infections. But clearly the group that we know we've discharged or we've taken off antibiotics and they have done well for 5-6 years as children, as they approach puberty and become sexually active, that increases their risk somehow. And so it becomes important for us to offer the family a choice at that point because clearly we don't have data.
Thank you. Great answer. So going on the same along the same way in terms of follow-up, they're asking if we really need to repeat ultrasounds for those patients who are asymptomatic. Is going to change the management?
Yeah, I do because ultrasound is non-invasive. It also allows them to come back to my office or clinic once a year for a touch-up. And how many times have you seen children that at age 5 were doing great, and then they come back at age 7 and 8 and they're drifting into holding for hours or a bit of constipation. So I bring children back to my office once a year until age 5, and then I bring them back around age 7, 8, and then again at age 10. And in every one of those visits, they get a Euroflow and post-void residual to look at their flow curve, make sure they're not dysfunctional voiders, and make sure that they're not constipated, because we can look at the rectal diameter during the post-void ultrasound. And then go over, good measures of managing their bladder and bowel, just to reinforce these, because people and families and children tend to forget over time.
Thank you. In terms of, you made great emphasis on the treatment of bowel bladder dysfunction. So one of the questions was how to treat or even diagnose the BBD in young girls, and then if you think there is a role of biofeedback in older kids with vascular reflux.
Yeah. So in the younger population, we tend to make the families keep a diary for us. If they're toilet trained, then they do bladder and bowel. If they're not toilet trained, then they just do bowel. We also measure the rectal diameters on the ultrasounds at every visit to try and correlate that with their history. As they get older, if the child comes in and they have a staccato type of flow rate, and as I said, we do get regular flow rates on these children. If they have a staccato type of flow rate, then we'll again reinforce the importance of getting rid of constipation and not holding. And if they still have issues with complete emptying, then we'll do biofeedback for sure.
Thank you, Dr. Khoury. I think this, again, was a great presentation. I think we're approaching our last 30 seconds. So I really would like to thank you from the bottom of my heart on behalf of the SPU. It was a great lecture. As always, very evidence-based approach, risk stratification. And I think really the audience really enjoyed the talk. Thank you very much. And big hi to the family.
I appreciate the invite again. It's a great honor for me. And thank you and congratulations on a great program. Too bad we couldn't all be together. Thank you.
Thank you.